So the panel was spectacular as always. Every year they impress the audience, and they're always the highlight of this conference. It was interesting to me listening to all of them when they were asked what their greatest fear was, that they all more or less said that they were afraid of losing themselves. And I thought that was particularly interesting because Dr. Alzheimer's first patient, Auguste D., said the same thing, that she had lost herself. And it's just amazing what this disease does to individuals and their families. Anyway, the panelists are always a very hard act to follow. And if anyone can follow them, it's our next speaker, Dr. Laura Mosqueda, who is the chair of the Department of Family Medicine and the director of the program in geriatrics here at UC Irvine School of Medicine, where she holds the Ronald Reagan Endowed Chair in Geriatrics. She is also the co-director of the National Center on Elder Abuse and UC Irvine Center of Excellence in Elder Abuse and Neglect. She has been listed as one of the best doctors in America in geriatric medicine numerous times, including 3 years in a row from 2009 to 2010 and 2011. She is widely recognized not only here in Orange County and on campus for her leadership in prevention of elder abuse, but indeed internationally. So let's welcome Dr. Laura Mosqueda.
Hello. Thanks a lot for letting me go on after that. Really appreciate it. I'm just starting a timer here for myself. And it's a pleasure to be here, and also a little embarrassing to talk after hearing the speakers this morning, who were fantastic, and then hearing this panel that was absolutely tremendous. And I think what I'm going to do, since it's a little bit after lunch and you might be kind of in that postprandial haze, and that this is going to be a little bit of audience participation, because as I was thinking about my talk, which is on behavioral disturbance and partnerships for problem solving, I think we can use some examples from what we just heard. So I'm going to ask you to help me come up with some examples on a few of the things I'm talking about here from the people we just heard, okay? So that means you have to stay with me, okay? All right, so let's go, and I'm either gonna forward a slide or open somebody's garage door. I think I just opened somebody's garage door. I'm just gonna use this. All right, so for those of you who can't see this in the back, it's a sign that says, "Attention dog guardians," not dog owners, dog guardians, pick up after your dogs, thank you. And then below that it says, "Attention dogs, grr, bark, woof, good dog." And the reason I put this slide up is because I think one of the great opportunities we have at this conference is bringing together professionals and caregivers, paid, unpaid, family members, people who have mild cognitive impairment or dementias, and trying to get us to speak the same language, which we often don't. And so this slide reminds me of the fact that we need to really try to find ways to communicate with each other and speak the same language. And so what I wanted to talk about when I was asked to talk about behavioral issues, as we often call them, is this idea of partnerships. That we need to partner with a person who has dementia, the family, the loved ones, because we all know that dementing illnesses are not just an illness for the person who has them, but really for the whole family. And sometimes when we talk about the difference between disease and illness, disease is that kind of physiologic issue that somebody has, but illness is how that disease fits into the context of a human being in your life. And understanding that, I think, is especially important when somebody has a dementing illness. And the partnerships also need to go with members of the healthcare team: physicians, psychologists, pharmacologists, social workers, occupational therapists, and who else? Who did I miss? Nurses. Who else? Activity coordinator peoples. What? Podiatrists? Yes? What? They're important. Psychiatrists, podiatrists, physiatrists, it all sounds so similar. Pardon? GCMs, also known as geriatric care managers. Gerontologists, yes. Dentists, yes. Physical therapists, speech and language pathologists, what? Spiritual directors. Where are the Carmelite sisters? Hello, yay, okay. Little gang from Duarte that I love so much. All right, so we all need to form partnerships in order to really have, in order to serve the purpose of why we're here in terms of helping each other. Because it's not just the person with dementia who needs help, it's everybody who loves them, and frankly, it's the healthcare providers too, I think, as we heard today. So the first thing I think we need to figure out is what is a behavioral disturbance. And sometimes the way I think about this, you all know who this is. The boss, okay, Bruce Springsteen. Bruce Springsteen was asked a number of years ago to give a speech to induct Bob Dylan into the Rock and Roll Hall of Fame. And he gave the following story. He said, "The first time I heard Bob Dylan, I was a young teenager, wasn't allowed to drive yet. I was in the car with my mom. She was driving, I was in the passenger seat, and Bob Dylan came on the radio, and I heard Blowin' in the Wind. And at the end of that song, I was stunned. It felt like somebody opened up my skull and kicked my brain and just woke me up. It was this amazing experience. And I looked over at my mother, and she also was just so amazed, you know. And we just sat and looked at each other for a moment. And she said, 'That man cannot sing.'" So here you have two people who have ostensibly the same experience at the same time under the same circumstances, who have entirely different reactions to this, right? And I just love this story because it helps me keep in mind that when you talk about things like behavioral disturbance, this seemingly simple term means different things to different people based on how we're experiencing them. If I'm the person with dementia, what might be a behavioral disturbance to the person who's living with them, and what might be a disturbance to the healthcare provider. And so having a common language, whenever somebody, for example, comes in and says to me that their loved one is agitated, I really try to back away from that and say, give me some behaviors of what you mean by agitated, because my agitated might be really different. I'll bet if we went around the room, how many people are here? I don't know, like 3,000 of you. We would get 3,000 different definitions of agitation. So we all mean different things, and we all experience them differently, and we all have different levels of tolerance for them as well. So it means different things to different people. Now, I think it's important also to help interpret behavioral disturbance. And again, I'm trying to get some better communication here. So for the person who comes in grabbing the lapel of my white coat and saying he's agitated, you have to do something, we want to know things like, how severe is it? Are there fluctuations? Are there patterns? Is it always worse at this time of day or that time of day? Is it always worse, you know, when my mother comes to visit, kind of a deal? Sorry, Mom. What are your perceptions of what this is like? What are the expectations that people have when somebody has a dementia? And all of these help us interpret behavioral disturbance. Does that make sense? And so these are the kinds of questions that I might be asking when somebody comes into my office complaining about a behavioral problem. It is amazing to me the number of times somebody has talked about something like agitation, and it sounded really, really severe. Then you think you need to do something about it, and then when you find out how often it occurs, it may be once a month, right, versus once a day. And so understanding all of these things are very, very important. So examples of behavioral disturbances include things like hallucinations. Did we hear about hallucinations? Okay. Delusions. So a delusion is a fixed false belief. Pretty simple. It's a fixed false belief. What is the key word in there? No, actually, see, the key word that we always pick up on is false, but really the key word is fixed. Because what do caregivers try to do when somebody has a delusion? change their mind. See the key word now? Fixed. Ain't gonna happen, all right? And so that's an example of behavioral disturbance as well. And then paranoia, which we didn't hear about today, but which is also a very, very common behavioral issue that comes along, where there's a sense that people are out to get you. It can be very, very frightening for folks, okay? So these kinds of behaviors, like what's the big deal about having a behavior problem? And the big deal is it can result in some real problems. It can result in aggression and violence by the person who has dementia. Did we hear a little bit about that today? What did you hear from the panel? Jumping out of the car, pounding fists. Okay, right, okay. It can result in some real upset, in agitated behavior, a lot of moving around and crying, etc. We heard about some withdrawal, right? And some sadness and crying. It can also result in abuse. And I'm just going to mention that because abuse can go both ways. And one thing we know, one of the few things we really know about abuse in people with dementia is that if a person with dementia has either physically or verbally aggressive behavior, they're more likely to get hit by a caregiver. And one message I want to give you, and this is a hard one, but I think it's important, is that anybody can be abused and anybody can be an abuser. And we really have to understand that. The very finest people can end up losing control and hitting somebody. And we're going to hear a little bit more about methods to cope with caregiver stress, which I think are going to be very important to prevent abuse. But it turns out that abuse in people with dementia is very, very common. And while it is understandable, because it is such a frustrating experience, it is not excusable, and it cannot happen. So it's really important to pay attention to behavioral disturbance because it can lead to really some pretty awful situations for folks. I think we have an arsenal of approaches. What did we learn about medications today? Oh, not so good. Yeah, maybe that's not the way we want to go. So why is it that everybody's getting medicated? Why? It's so easy. Thank you, Karen Carlson, a wonderful occupational therapist. It will take me much less time if you come in and tell me that your husband is agitated for me to pull out my prescription, or these days we don't pull them out, we type on our computers so that we don't have to look at you, and write a prescription for a dangerous antipsychotic medication, and you will go away happy thinking that I've given you something that will help. It's taken me all of 2 minutes, and I didn't have to spend any time doing something crazy like talking to you. And so that's why I want to talk about this arsenal of approaches, because I do believe in medication. I prescribe medications, but I guarantee you in my career I've stopped more medications than I've ever started. And so they need to be used judiciously and with understanding, and we'll talk a little bit more about that in a minute. And these are not, well, I have to choose one of these. No, this is a buffet where you can have a little bit of everything, all right? So when we talk about this arsenal of approaches, it's both important for the caregivers to know about these and for healthcare professionals to know about these so that we can help each other identify what might work, which of these might work in your situation. Reassurance. Reassurance is not a pat on the head. I do not mean this in any sort of a patronizing or demeaning way. But I do think that reassurance can be it has no side effects, so it's not dangerous. It's not too annoying to actually do. It's not harmful to anybody. Did you hear any examples? This is now the real audience participation part of reassurance. Give me one or two examples that you heard. Yes. And I'll repeat it for everybody. Don't panic.
When the spouse was able to tell their loved one that they still care about them and respect them and are there for them in their words and in their actions, that's giving reassurance.
So that's a beautiful, beautiful example that a spouse was able to really say to this person, you know, I know you're afraid, but I'm still here. I'm here for you every step of the way, and I still care about you, and I still love you. Did I paraphrase you right? That's a great example of reassurance. Guess what? Healthcare providers can also provide reassurance. Healthcare providers can tell patients and families, even though we've made this diagnosis, because one of the things I think that's scary is you don't make a diagnosis of Alzheimer's disease and then wish somebody good luck. We make a diagnosis of Alzheimer's disease or any other form of Lewy body and whatever it is, and then say, this is the diagnosis, and I'm going to be there for you every step of the way, and if I don't know how to do this, I'm going to find somebody who can. That's another form of reassurance, right? No? You're shaking your head no? You don't like this? Why are you shaking your head no at me? Oh, we're okay? Okay, I don't know, somebody over there was like, nah, I don't think so. Okay. I just needed a little reassurance. Yeah. Do you have any port? Unfortunately for my husband, I am not a cheap drunk. Education. I think education is also very, very important. Education about the illness and approaches to behavioral problems and realistic expectations. And I've become very, very interested. There was a speaker earlier talking about empathy, among other things. I'm very, very interested in this concept of empathy, particularly for people who have demanding illnesses, to try to understand what it is somebody might be experiencing. And I think this is where education becomes very important. And frankly, I think this is where elder abuse becomes important too. Because if we can try and understand what that person might be experiencing, I think it can help us have a more loving and understanding and gentle approach and be a little bit less frustrated as well. It doesn't take it all away, but I think it helps. And I vividly remember a family in my office, and this woman clearly had Alzheimer's disease. By the time she saw us, she was fairly well into the illness. And he really was stuck on this idea of, she can remember who her third grade teacher is. Why is she asking me the same question over and over again? She's not trying hard enough. Have we heard all that? And I can understand why somebody would feel that way, can't you? I mean, this guy didn't understand the illness that well. He didn't understand that it's like having your record button broken and you can't make new memories when you've got Alzheimer's disease. He didn't understand that it wasn't just a matter of effort, and he kept going back to that. And his sisters were getting very frustrated with him, and we were trying to explain it to him, and he was having trouble hearing it. And finally I said, I want you to stand up on this table, flap your arms as hard as you can, and fly. Because that's what you're asking your mother to do. No matter how hard she tries, she cannot do this. It is not in her brain. She is not able to do this. You can't expect that of her. And so sometimes we have to go to these extremes. Fortunately, he didn't stand on the table and try it. So we were glad there. But he was kind of it was very hard to get. So sometimes we have to really figure out what method of communication is going to work with this individual, with their background, with their relationship with their loved one, in order to get the message across. So sometimes I think education is really important as well. Realistic expectations. Did we hear something about that today too? What did we hear a little bit about education and expectations from the panel? Education about depression. Like, what? I don't know from depression, right? And so what does this even mean? And how do I understand it? And that, I thought, was a great example of lack of communication, of us assuming that we use a common word like depression, or common words like agitation, common phrases like behavioral disturbance, and assume that we're speaking the same language. It's back to that communicating with the bark, bark, woof, woof when you're trying to talk to your dog. So education is extremely important, and a little bit of education can occur at every office visit. Can it? I mean, we can all take, for us in providers, we can all take a minute or two to just do a little bit of education, hear where people are, find out what they need, refer to wonderful resources like the Alzheimer's Association if we need to, and help. And we can also take the time to listen to our patients and our families and have them educate us so that we can every day be a little bit better than we were the day before. Environmental modification. I didn't hear this talked about much, other than tripping over the cat, the fake cat. And I want to spend a minute because I had this extraordinary experience a couple weeks ago, or less than that. I was on a house call. And this guy has Alzheimer's disease, and he's in a wheelchair now. And the family was telling me that he was getting very, very agitated at times. And there was no pattern to it. We couldn't tell when. And he would just get really agitated, particularly when he was sitting near a window kind of a deal. But he liked looking outside, and so it was just a kind of a weird thing. And they were really wanting me to, what do you think they were wanting me to do? Prescribe a medication. So I did. No, I'm just kidding. I didn't. So I went on a house call, and he was sitting in front of this window, and then he started to get agitated. And I saw it happen. And he started to get very, very agitated. And what I did is I went over right next to him, and I looked from his perspective where his eyes were, what was happening, and there was this horrible reflection coming up from the street into his eyes. It would have made any of us agitated. But because he was no longer able to say very many words, the only way he could express himself was through this behavior, this agitated behavior. So the only medication he needed was for me to move his wheelchair back about 2 feet. And the agitation went away. And that was such a good reminder for me of the importance of understanding things from the person with dementia's perspective. That's why I added on a day ago, literally and figuratively, to that. Because it really was a good lesson and a good reminder for me about how we need to understand what somebody might be going through. The other thing is sometimes there's triggers like mirrors that are very disturbing. Well, they're disturbing to a lot of us for a whole variety of reasons. But we do know, it's amazing to me how many times I've heard somebody say, well, he really gets upset when he looks in the mirror, and nobody thought to say, well, maybe take the mirror down or cover the mirror. And I know it sounds silly, but I think as a caregiver, when you're in the throes of all this stuff, some of these obvious things kind of go out the window, and that's why this collaboration with so many different healthcare professionals can be helpful. One of us at some point will think of it. There are certain rooms or there are weird reflections that can get misperceived, et cetera. So helping people understand from the person's perspective, I think, is a very important thing. Talk therapy. That's what non-people who aren't like psychologists and social workers call it, like me. Talk therapy. So, support groups. Did we hear about support groups today? How many people are in support groups here? Yay, wow, a lot of you. Mazel tov. And it's clearly a great thing. But you know what? Some people hate support groups. Some people will not go to a support group. They're not interested. They don't want to hear everybody else's problems, kind of a deal. It just doesn't work for everybody. But what we do have is we have it available for those people where it does work. Some people really prefer some brief counseling, some one-on-one kinds of things. Psychotherapy can be very beneficial. And this is true, right? This works for people who have dementia as well. And so often, I think, especially in the early stages and people with mild cognitive impairment, we discount the idea that they can benefit from therapy, and it's not true. They can benefit, right? So did we hear about anything related to this in today's panel, related to talk therapy? I'll give you a hint. Yeah? What do we hear about? Being a part of a support group, right? Figuring out what depression is, getting it adequately treated. And the other thing that we learned, and that I was reminded of, back to communication and language, is, I don't know from depression. I don't know what that is. And then we heard somebody say, but I get so angry and so frustrated, right, and so short-tempered, and guess what? Those are symptoms of depression. So if we just had better communication or kept our ears open to these language, so when I hear somebody saying that to me, my mind is going to depression, but that's not how they think about it. So I don't ask people very often, are you depressed? I'll say things like, Have you been feeling more short-tempered lately? Now, usually when you ask that question, if there's a couple there, look to the spouse to see how vigorously they're nodding their head. That's something else I've learned. Person will go, maybe a little bit, and the spouse is, yeah, very short-tempered. Okay, so we want to pay attention to this, and then we want to treat it, and it doesn't necessarily require medication to treat, but we know that medication can help, and it can especially help if done in conjunction with something else. We're going to just mention medications because I felt like I had to. As I said, I do prescribe them. I do think that they can be very useful at times. And so any of these kinds of classes of medication can be used. And when I'm trying to figure out what medication to use, I'm working with my family and I'm saying to them, we're going to make an educated guess about the medication, and we're going to make it together. We're going to make, this is called shared decision making. So, we think it's time for a medication. Let's decide together what would make the most sense. And so if we're going to look, for example, at an antidepressant medication, there's a whole huge number of medications that treat depression. What's the difference between them? They all treat depression. My question is now, what side effects do we want? Because they all have side effects. Some side effects can be beneficial. So if you have somebody who's depressed and is having trouble sleeping, you might want to choose an antidepressant that helps sleep and give it to them at night, by the way, right? These are the little things we forget to mention very often to our patients. If we have somebody who's depressed and also quite anxious, we might want to choose an antidepressant that also has more anti-anxiety kinds of effects on it, right? So the question is, what side effects do we want? What other benefits can we get? And when you're really lucky, it's 2 for 1 day, and I can choose an antidepressant that will also help you with your urinary incontinence. Yay! Everybody's happy. Then I have to stop the medicine you're on for the urinary incontinence, however, okay? So we're always looking at when we can find those sorts of situations as well when we're starting a medication. Then the next thing after this educated guess and shared decision-making is discuss realistic expectations. Because if I don't tell you we have somebody who's very psychotic, they're hallucinating, I would like to hallucinate cats. If I have to hallucinate, I love cats, so that would be cool with me. But what if I was somebody who was terrified of cats and that's what I was hallucinating, right? So we need to understand that and discuss realistic expectations. We're going to start this medication. And what we're going to do, this is what I'm going to say to a family and to my patient is, I'm going to hope this is going to make you 50% better over the next month. And we're going to aim for more, but that's kind of what we're looking for. And I'm starting you on a super low dose, so I don't want you to be afraid when we start going up on it a little bit. So that I don't have somebody walking away thinking like, great, I'm going to start this medication, I'm going to give it to him tomorrow, no more cats. Right? So realistic expectations, I think, are very important. If the medicine isn't working, we either need to raise the dose or stop using it. I've met a lot of people on pain medications who are still having a lot of pain. So something's not working there. Same is true with these classes of medication. And if it is working, as we heard before, at some point try to stop using it. And this is something where I really work with my families, because I have some families who have just been to hell and back with behavioral issues. We have somebody, they're doing fine, they've been doing fine for several months, and I'll say, what do you think maybe is it time to try and taper off? And some of them just go into a complete panic and say, please don't do this to me. And the person isn't seem to be experiencing any bad side effects, I'm not real worried, and I'll say, okay, let's just give it a little more time, but let's talk about it again next time. Versus some people who say, yeah, things have really been going well, and gosh, I'm noticing a little bit of stiffness. Let's try and taper off and see how we do. And I give my caregivers a lot of control over, hey, if things are beginning to ramp up again, just let me know what's going on. And I work with wonderful, wonderful pharmacologists who also check in with families to help us figure this out. So in order for partnerships to work for these sorts of things, there's a few necessary elements. We need to listen to each other. And healthcare providers especially, we need to listen to our patients and our families. The communication we talked about, using language in a commonly understood way, understanding expectations, negotiating what we want to have happen. So that it isn't some expert from on high telling you what to do, but that we're thinking about it together and understanding what's important and what values are important to you and what makes for a quality of life for this individual and their family. Empathy, I think, is supremely important. These are necessary elements for a collaborative partnership. And of course, compassion, again, going both ways. I find that so many of my patients and families have been compassionate to me when I'm having a bad day, and I'm like, I'm sorry, I don't have time to go over this, and somebody will say, you know what, I understand you're having a hard day today. And hopefully, we're giving that compassion back to our patients and families, as we certainly ought to. So everybody's going blah, 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 for you can't read, blah, 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 and everybody's thinking in a thought bubble, shut up, shut up, shut up, shut up, shut up. We do need to listen to each other. And I just want to end by saying I know sometimes the collaborations and partnerships are a little bit weird, but we can all be going the same direction and have a little bit of fun together and really make things work so that we're improving quality of life for our patients and our families and having fun along the way too, so that there's a little bit of laughter involved, which is, I think, also critically important when we're dealing with such a serious and difficult sort of an issue. So thank you very much for your attention. I enjoyed talking to you. Thank you.
Take a couple questions.
Okay.
Okay, so since the panel's coming up, let's just take a couple questions real fast from the audience, and then Dr. Mosqueda will be here to address other questions that people may have. So we'll take one on each side of the room if there are any. Come on, don't be shy.
Tired. Bored.
Oh, here, Linda, over here.
Thank you. When do you think a patient should be told of their diagnosis? And taking into account that most physicians don't have the communication skills that you've just described, and the reality is when the doctor says, oh, you have Alzheimer's, see you next month, it's devastating. So how do you think it should be handled?
Well, I'm going to respond in two ways. One is we're really working to change that. Every medical student at UC Irvine now has a required rotation in geriatrics. We're one of the few medical schools in the country to have that. And I have told medical students that if they ever behave that way, that I will find out and personally hunt them down and kill them. So, I mean, I think we're working hard to make it better. This is just, and I know it's going to take a long time, but we're working at it. I believe that everybody has a right to know their diagnosis at some point. I don't think you have to shove it down somebody's throat before they're ready to hear it. I try to take a pretty gentle approach, and I'll say to somebody, you know, I'll see if I can have them ask me what's going on. Sometimes I've had experiences where I've said, well, you know, somebody will say, well, I just have a little bit of memory loss, but that's normal. And I'll say, well, actually, you know what? This is a little bit beyond normal, what you have. This is actually an illness or a disease. And they'll go, yeah, but I still think it's normal. Kind of, you know, we'll have a little bit of that, and they're just not ready to engage in that conversation. And we'll, you know, at some point, people will be ready, and families will be ready. Families usually are ready sooner. So I don't shove it down somebody's throat because I think that can just be cruel. But I also want to be ethical so that they can participate in their own healthcare decisions. And part of it depends on the kind of dementia they have and the relative preservation and impairment of different areas of cognition and what stage they are in terms of the conversation. So we really try to tell everybody, and we try to do it in a way that's loving and supportive, and truthful all at the same time. But if it doesn't happen the day after we know, I don't think it matters if it happens a month later.
Laurel. Let's go on this side.
When you were talking about mirrors and weird reflections, it occurred to me that that's a really basic, primitive kind of response, and it reminded me of what Temple Grandin has looked at with cattle, and I wondered if anyone's made the connection between those kinds of reactions that cattle have, dark shadows and bright lights.
I don't have a lot of bovine experience. I have a steak on occasion. Yeah, but it's a really interesting point that you're making in terms of you know, sometimes that fright or that unexpected and how we react. And it does perhaps get to the more primitive parts of our brain as well. So it's a really interesting question, but I don't have a good answer.
Okay, one last question because we're running out of time.
We spent a lot of time talking about medications today, and you mentioned taking people off of a medication or slowly increasing it. Is there a rule of thumb that you have for a length of time that you should look for in prescribing something and the reactions to it?
Yeah, it's a little bit individualized because it depends on what the medication. Some take longer to kick in than others. And so the rule of thumb is you always talk about it. And taking into account what we call the pharmacokinetics and pharmacodynamics of an individual person, like depending on what their kidney function is like, et cetera, you know, you try and give them an idea of what to expect and when to expect it. And it's different for different medications and different people's physiology. So the real rule of thumb is always discuss it. Our rule of thumb in geriatrics when we start any medication is start low and go slow.
Very good. Thanks, Laura. Thank you. Let's thank her again. Wasn't that fantastic? So I am really impressed looking out here how crowded the audience is and how everyone is staying to the end. That's fantastic. I think it's a reflection of the high quality of the speakers and their talk today. But I think we have all learned a little coffee break, and so Viorella is going to make a quick announcement, and then we'll resume here in a half hour.